Hello, this is Dr. Cosby bringing you part 2 of the ankle and lower limb lecture series. Part 2 will be focused in on the pathologies of the ankle and injuries that actually happen to the lower limb. But I do want to kind of hammer home the fact that you should go back, rewatch the anatomy portion to this lecture series because it becomes instrumentally important to understand the functional anatomy of the ankle and lower limb in order to have a really good understanding of how each of these pathologies occur. But without further ado, the first pathology that we'll talk about is the acute ankle sprain. We're going to talk about the acute ankle sprain first because it's the most common pathology that you're going to see occur in the ankle and lower limb, at least in the athletic training clinical setting world. So what we know about ankle injuries is that when we're referring to a lateral ankle sprain, at least, that the mechanism of injury is a supination of the rear foot, right? In other words, there's a plantar flexion inversion moment that occurs at the foot. Now, a lot of clinicians would say that you could have either a plantar flexion moment, you could have an inversion moment, or you could have a combination of the two. And here's why knowing anatomy becomes extremely important, right? What we know about the anterior talofibular ligament, right, is that it has two attachments, one to the fibula and then the other one to the talus. And so if we think about anatomically where that ligament lies, we know that the plantar flexion moment is what's going to cause injury to the ATFL in isolation. We know about the inversion moment, right? That calcaneal inversion moment is that the calcaneal fibular ligament attaches to the calcaneus, the lateral side of the calcaneus, and the distal fibula. So any inversion moment, and we have an injury to the calcaneal fibular ligament, right? So it is possible to have an isolated ligamentous injury such that there's just a plantar flexion moment or there's an inversion moment, but most often what we see in about 60% of most ankle sprains is there's a combination injury moment where there's a plantar flexion plus inversion moment, thereby rupturing or causing injury to both the anterior talofibular ligament and the calcaneal fibular ligament, right? And so in terms of the mechanism of an acute ankle sprain, it's typically plantar flexion and an inversion moment, right? Now, there are two things that we have to consider, the obvious and the not so obvious. So when we have an ankle injury walk into our clinic, right, the obvious things that we're looking for when they tell us with our history questions that they've inverted their foot and plantar flexed their ankle, right, is what? A sprain to at least one of the three lateral ankle ligaments. That would be the obvious. But what are some of the not so obvious injuries that could occur by way of plantar flexion and inversion moments? If you said maybe compression to the deltoid ligament on the medial aspect of the foot, then you'd be correct. If you said an avulsion to the distal fibula, then you would be correct, right? Did you say a fracture to the distal fibula? Then you certainly would be correct. So the obvious is what we're looking for, which is the lateral ligamentous ankle injury. The not so obvious is all of the things that we don't expect to happen, but that can happen with that injury mechanism. We have to be thinking about these things because a lot of times what gets missed in an ankle evaluation isn't the obvious, it's the not so obvious pathologies, right? And that could go on to plague your patient, right? So let's take a look at this video here. What we're going to see is a mechanism of injury for an ankle sprain, right? So keep looking, he's gonna land and you'll see that foot go into mainly inversion, right? We don't really see that plantar flexion moment and that happens relatively quick, right? That was slow-mo, but let's look at it again. There's plantar flexion and now we have inversion and it's a quick snap back, right? So imagine being the athletic trainer on the sideline occupied and maybe you didn't see that quick mechanism of injury. This is where your evaluations will become extremely important as you're assessing a patient who walks into your clinical setting. So in terms of lateral ankle sprains, it's no secret they're my favorite injury in the entire human body. I know. I don't know why I like the ankle, but I do. I think it's because it's the point in which all of our ground reaction forces are going to be transferred. So it's kind of the controller of ground reactional forces. And so I think that's what intrigues me the most. But in terms of lateral ankle sprains, what we know about them is that 90% of all ankle sprains are typically going to involve the lateral side of the ankle. In fact, at least 90% of them are going to involve some type of plantar flexion moment, which means it's going to involve the ATFL ligament at least, right? There are other ligaments that it could involve, but for the most part, plantar flexion moment injuries seem to be the highest in terms of the mechanisms of injuries reported for those that actually have lateral ankle sprains. And then the 10% of the ankle sprains that we see come into our clinic will be those of an eversion mechanism, right? So in other words, the calcaneus is going to move into an eversion moment. And we already know that the deltoid ligament is on the medial side of the ankle. Therefore, it's going to get stretched and we're going to have a sprain of that deltoid ligament. So rest assured that you could potentially see deltoid ligamentous sprains, but most often it's going to be a lateral ankle ligamentous sprain that you are going to see. So in terms of grading sprains of the ankle, it's pretty simple. I think we've talked about this multiple times. We'll call that learning over time. Essentially, with a grade 1, you get a stretch of the ligament, but there really isn't any tearing, right? That's the biggest thing here, is that in a grade 1, you don't have tearing of the ligament itself. And so essentially what you get is a little bit of swelling, maybe some tenderness, but there's very little loss of function. This patient is extremely functional. They just stretch their ligament. And I shouldn't say just, but the reality is we don't have the actual tearing, right? In a grade 2, we have partial tearing of the ligament. So there's these macroscopic tears within the ligament, which means that ligament is compromised and it's going to require time for those macroscopic pieces that are torn to kind of heal back together. Because we have that macroscopic tearing, right? What we'll see is there's an increase in the patient's perception of pain. We see that swelling is increased in this particular injury and their tenderness to palpation over those ligaments. So we're starting to see differentials as we move or progress through the grades. And those differentials that we're seeing really have to do with what's torn or what's stretched, right? In a grade 3, we know that any grade 3, whether it's a sprain or a strain, is always going to represent a rupture, right? In this particular case, it's going to be a rupture of a ligament, but certainly could be a rupture of a tendon. And so with this, we see, because there's a rupturing, a complete disruption, right? We will see severe swelling and most often hemorrhaging or redness or bleeding in the area. We would call that ecchymosis, right? They're going to be tendinous to palpation. And the hard part about ankle sprains with the grade 3 is they won't be able to bear weight. They won't be able to function on it because there'll be so much instability. Now it's here that I stop and I say this, because when we look at this grading scale, right, when we look at grade 1 through grade 3, we'll say, oh, it's just a stretch of the ligament. It's no big deal, right? Because we're looking at the grading scale and we're saying, well, there's no macroscopic tearing, a little bit of stretch of the ligament, but the ligament is intact. There's no swelling and they're picking functional, right? But the problem is with ankle sprains is, what did we say, or what did I say in part 1 of this series? That what's the greatest predictor for someone suffering from another ankle sprain? It's history of an ankle sprain, right? So if we treat a grade 1 like it's no big deal and we return them to play, and guess what? They are at a high risk of re-spraining that ankle and becoming a chronic ankle instability patient. So I'm saying, as you progress from becoming students to becoming professionals, starting to look at the ankle joint as much more than just an ankle sprain becomes drastically important for you as you progress in the clinical setting. So you don't have patients coming back to you asking you for help because you returned them to play too soon because they had just a grade 1 injury. All right, you guys, so let's get into the fun part, which is going to be special testing, right? I mean, this is the reason that we're in this class, to learn how to assess these injuries, right? So the gold standard test for assessing a lateral ankle ligamentous sprain is going to be the anterior Jord test. The anterior Jord test is only used to rule out or rule in injury to the anterior talofibular ligament, so the ATFL. So this is a special test that we want to use if we suspect the patient has an anterior talofibular ligament sprain, which we said in 90% of the cases is probably going to be the case. So this is a special test that you absolutely need to know how to do or how to perform in the clinical setting. And lucky you, we're doing that in lab relatively soon. So when we think about special testing, since this is the first time that we've actually kind of started talking about special testing is done to help us diagnose a pathology, a disease, an injury, an illness, right? And so with special testing for ligaments, there are 2 ways that the test can most often be positive. A test can be positive for pain, right? Or a test can be positive for laxity and or looseness. In this particular case, for the anterior Jord test, we are assessing the laxity or looseness of the ligament, right? So a positive test would be one in which the foot slides forward or anteriorly. Now let's think about that. We said the role of the ATFL in the first part of this series was to do what? To prevent anterior translation of that talus, right? So if it's ruptured, the talus and the calcaneus are going to slide forward away from that tibia, right? So a positive anterior drawer is one in which the foot can continue to slide forward like an anterior drawer. Now, you see these two numbers down here, sensitivity and specificity. What do they mean? In evidence-based practice, you're going to learn about them in a few short weeks and you'll have a better understanding. But for today's lecture, let's just define them really quickly. The sensitivity of a test is the ability of a test to rule out the pathology. So we see these numbers that sit next to the sensitivity and specificity, and we say, what are those? So this 0.78 represents how well that test is at ruling out a pathology. So let me say it this way. In this particular case, if the anterior drawer test is negative, then we are 78% sure that that patient doesn't have the pathology, right? So let me say it again. A highly sensitive test is a test that is good at ruling out pathology. So if that test is negative, we're sure they don't have it, right? In this particular case, the sensitivity of your anterior drawer test is 0.78, which means if we get a negative test, there's no laxity. When we do the anterior drawer, we're 78% sure that that patient doesn't have a compromise to the anterior talofibular ligament. Now, you guys might all say, well, Dr. Cosby, what's a good test to rule in an anterior drawer or an ATFL injury, right? Well, that's the specificity. The specificity tells us this. If a test is positive, how likely it is at ruling in the pathology, right? And so a highly specific test will be good at ruling in the pathology when it's positive. So if I have a positive anterior drawer, I'm 75% sure that that patient has an anterior talofibular ligamentous injury, right? These become important when we're trying to decide which special test to use to help us in our diagnosis. Now, for the ankle, it's pretty simple. We have one test to test the anterior talofibular ligament. So that's what we have. But in the knee, when we get to the knee, there are so many special tests for the ACL that we have to figure out which test is most sensitive and which one am I going to use, which one is most specific and which one am I going to use, because we'll have 15 different knee tests, right? In this particular case, the anterior drawer test is the only test that we have to rule in the ATFL injury. And so we just need to know if it's negative, right? If it's negative, we're 78% sure that they don't have it. And if it's positive, we're 75% sure that they do have it. Now, here is the anterior drawer test being performed on an actual ligamentous injury. And so you can see how that talus or that calcaneus is gliding anteriorly, and you can see that movement across the talocrural joint. Normally, if that ATFL is intact, you won't get that gliding or that sliding of the calcaneus and the talus. So that, in essence, would be a positive exam or a positive anterior drawer test, and we would be 75% sure that that patient has an anterior talofibular ligamentous sprain. Moving on, the next special test is the talar tilt test. Some may call it the inversion talar tilt test because it describes the direction in which the clinician will be driving the foot as they test the actual ligament itself. So we, in this particular case, because it's an inversion talar tilt test, we are going to be assessing the integrity of the calcaneal fibular ligament, right? And if we look at the inversion talar tilt test ability, we would say that we probably want to use it to rule in the pathology because we're 75% sure when it's positive, right, that they have a calcaneal fibular ligamentous sprain, right? So we're more sure when it's positive than we are when it's negative, right? So this is a really good test to use in the clinical setting. It's the only test that we have, really, quite honestly, for the calcaneal fibular ligament. And so it's a test that we're going to use, and we'll learn it in the lab setting, but it is going to rule in a calcaneal fibular ligament sprain. Now, we talked about in the first part of the series about the glide of the talus and arthrokinematics, right? And we said after an ankle sprain, what we know about ankle sprains is that patients will lack dorsiflexion range of motion. And the reason they lack dorsiflexion range of motion has to do with its ligamentous attachments. Remember this, if 90% of ankle sprains involve the anterior talofibular ligament, and the anterior talofibular ligament is the only ligament that attaches to the talus, when it's torn, when it's ruptured, when it's stretched, that talus is going to glide or be stuck anteriorly. What that means is what? Arthrokinematically, that talus can't move posterior. And if that talus can't move posterior, then essentially what that leads to is a patient who lacks dorsiflexion range of motion, right? Well, one way to test that clinically is to perform what's called the posterior talar glide test. And you'll see that here. Essentially what you're going to do is put your thumbs over the talocrural joint here, and you're going to glide that talus posteriorly, right? What we know is that when we glide that talus posteriorly, two things are going to happen. One, the patient's foot's going to move into dorsiflexion, but then secondarily, do you see how that knee is in a flex position? The talus glides posteriorly. We're going to move backwards, which means we're also going to get some knee flexion moment. So this test is an indirect way to assess posterior talar glide, which is an indirect way to assess why our patient doesn't have good dorsiflexion range of motion. Now, you all might be saying, Dr. Cosby, like, why? Why are you telling me this? Well, it becomes important when we're trying to figure out how we treat our patients, right? Someone said in our gait assessment, oh, if they lack dorsiflexion, then I'm going to stretch their gastrocs, right? Which is great if the restriction is coming from a soft tissue restriction, right? Like the gastrocs. But what if you keep stretching that patient, stretching that patient, stretching that patient, and their dorsiflexion still isn't returning? Why is that? It's because there is an arthrokinematic restriction that cannot be fixed with a stretch. You would have to do some type of joint mobilization across the talocrural joint to improve that patient's dorsiflexion range of motion. Okay, so I hope that makes sense to you all. So let's talk about when to refer. These are the Ottawa rules. These were rules that were pre-established in Canada, Ottawa, Canada. What we know about Ottawa is they have free healthcare, and so they had to establish a system, right? In other words, everyone would go to the ER every single time they had anything because they have free healthcare. So what they decided to do was look at thousands of ankle sprains and their actual radiographic evidence or their x-rays, and then also look at the signs and symptoms that the patient reported, right? And then they said, okay, based on these thousands of ankle sprains, all of the ones that were actually positive for fracture on an x-ray, what were the common symptoms that they reported over time, right? And so here's what they found. If a patient was tender to palpation on the posterior 1/3, you see that, of the lateral malleolus, if they were tender to palpation on the posterior 1/3 of the medial malleolus, or the navicular, or the base of the fifth, okay, any of those, then they typically had a fracture. Does that make sense? So 90% of the cases that reported to the ER room that had a fracture also had tenderness to palpation here, 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 or here, and they couldn't bear weight, right? So as you're in the clinical setting and you're evaluating ankle sprains and you're trying to decide, oh my gosh, do they need an x-ray? Do they not? If you're using the Ottawa ankle rules, right? This idea that they're tenderness to palpation on the posterior edge of the lateral malleolus, that they're tender palpation on the posterior edge of the medial malleolus, or the navicular, or the base of the fifth, and they can't bear weight, then you're going to be 90% certain that they have a fracture, right? And you're going to refer that out to make sure that you are correct. If they are not tender to palpation on any of these four sites, if they can bear weight, we typically do not refer out for an x-ray. These are the Ottawa ankle rules, and they are 90% accurate in their diagnosis of fractures following an ankle sprain. So I hope that you utilize this in your clinical practice. The next type of ankle sprain that we're going to talk about is a syndesmotic ankle sprain. This is completely different than the lateral ankle sprain. Let's review joints really quick. We have the subtalar joint, we have the talocrural joint, and then we have the distotibiofibular joint, right? An ankle sprain, a lateral ankle sprain, is one that's going to impact the subtalar joint and the talocrural joint, right? It doesn't cross over into the tibiofemoral joint. Your syndesmotic ankle sprain, however, is going to impact the tibiofibular joint, the distal tibiofibular joint. The mechanism of injury is also extremely different than your lateral ankle sprain. Most often, if we see high ankle sprains or syndesmotic ankle sprains, most often it's as a result of this forced dorsiflexion moment. It could be forced dorsiflexion and forced eversion at the same time, but most often we see it as just a pure full dorsiflexion moment, right? And if I had a foot in here, I'd probably show you what that looked like, but I don't. So just imagine loading in a squat, right? And keeping your feet pointing forward. As you load that squat, like if you were to really load that squat, you could kind of feel that distal tibiofibular joint spreading out, right? And so with these particular injuries, these are not injuries that heal themselves relatively quick, like the lateral ankle sprain. Because the distal tibiofibular joint is such a weight-bearing joint, these injuries tend to take a lot longer to heal themselves. So in terms of signs and symptoms, with the lateral ankle sprain, most of the pain is laterally. Most of the pain is going to be focused on the lateral, maybe inferior fibula. But with the syndesmotic ankle sprain, the pain is a lot more superior or proximally. You're going to have pain on the anterior joint, pain at that distal tib-fib joint, and then pain on the interosseous membrane, which holds, remember, that fibula to the tibia. What we're also going to see with these patients is that they're going to have a diastasis. And a diastasis, its definition essentially is literally just a widening of the joint, a widening or a de-articulation of the tibia and fibula distally, right? And so in terms of the recovery period, my goodness, I've seen syndesmotic ankle sprain take 8 weeks to 10 weeks to heal itself because it's such a weight-bearing bone, because the forces are being transferred right at that junction, that it takes a lot longer for this particular ankle sprain to heal itself. You may have noticed that I skipped something intentionally on this slide, and this is the long Mason-Nuvi fracture. And I want you to think about the not so obvious here, like we did with the lateral ankle sprain. If we load the distal tibiofibular joint in dorsiflexion, right, and we have a widening of those joints, I want you to think proximally what could happen at the proximal tibiofibular joint. Okay, cool. You've had a second to think about it. Now think about this. What if the force is transferred all the way up the fibula and caused a proximal fibular fracture? Good, because if you can envision that, that's what happens when the dorsiflexion force is great. It creates what's called a long Mason-Nuvi fracture, and that fracture is like a spiral fracture in the proximal portion of the proximal tib fib. And I have seen this, like it's a real thing. And you'll miss it because the fibular bone is what? It's non-weight bearing, so the patient won't feel the fracture. So always make sure that if you have a syndesmotic ankle sprain, that you palpate the proximal fibular head just to make sure that it's actually intact. So let's take a look at this injury here, where you will see the mechanism of injury. Do you see it there? The mechanism of injury for a high ankle sprain. We'll do it again just because that was so quick, right? So there it is. There's massive dorsiflexion, external rotation moment. We'll do it one more time. See it there? That is how you get a syndesmotic ankle sprain in football. Now, are there other ways to get it? Certainly, right? Olympic weightlifting would be an example. If you have so much weight on the bar and you can't control the load, you certainly could suffer from a syndesmotic ankle sprain. There are many ways to suffer. Again, it'll take anywhere from 8 to 12 weeks to heal themselves. So be careful. A lot of times with syndesmotic ankle sprains, we are actually going to put them in a non-weight bearing position. So we're actually going to put them in a walking boot. In terms of special tests, there are a few that we'll do in the lab. The first one is its name, force dorsiflexion and eversion test. So sounds simple. You're going to force them up into dorsiflexion and then evert the foot. And what you will visibly see is a widening of the distal tibiofibular joint, and they're going to complain of pain. And then the next test is the fibular translation test. So I'm going to show it to you. Do you see how lax and loose and how much movement we have of that distal fibula? So this is the fibular translation test. In terms of its sensitivity and specificity, it's a relatively good test to use, right? To both rule in and to rule out pathology. And then the last test that we have is the compression test. So imagine on the distal portion of the distal tibiofibular joint, just above where you suspect there's injury, you compress together the tibia and the fibula, and it causes a widening of that joint, right? That's the compression test. What we know about the compression test is that if that test is negative, they don't have it. We're 100% certain that if that test is negative, they don't have a syndesmotic ankle sprain, right? So this is a good test to use to rule out a syndesmotic ankle sprain right away. Okay, on to medial ankle sprains. We know that the medial ankle sprain is going to be caused by forced calcaneal eversion, and we know that it's most often going to involve the deltoid ligament, although I will say sometimes it does involve the calcaneal navicular or spring ligament as well, depending on how much eversion force you get at the calcaneus itself. But most often, the mechanism of injury is going to be calcaneal eversion, right? Signs and symptoms are going to be tenderness to palpation anywhere on these 4 bundles of the deltoid ligament, right? So again, what's the not so obvious? A fracture to the fibula if the eversion force is maximal enough, right? You could have an avulsion fracture of the deltoid off of the calcaneus on the medial side. So we want to make sure that we're looking for the obvious, but then also the not so obvious. So in terms of special testing, remember we talked about the inversion Taylor tilt test for the ATFL and the CFL, right? Well, now we have something called the eversion Taylor tilt test, which is going to assess the deltoid ligament, right? So in other words, we're going to rock that calcaneus out into eversion, and then we're going to do the Kleiger's test. And the Kleiger's test is essentially similar to the eversion Taylor tilt. Its major difference is that instead of using the calcaneus to evert, we're actually going to evert the forefoot. When we do that, what we're doing with Kleiger's test is we're assessing this bundle, right, of the deltoid ligament. Your eversion Taylor tilt test is going to be assessing these 2 bundles of the deltoid ligament itself, right? We want to make sure we're getting all of the bundles of the deltoid ligament. Now, considerations are what I've already said, the not so obvious. So number 1, will we have a fibular fracture on the lateral side if the force is too great? And then number 2, the medial longitudinal arch, in particular, that spring ligament or the calcaneal navicular ligament, if the eversion mechanism is great enough. Okay, the os trigonum is a very small anatomical structure that sits on the posterior aspect of the talus. It's known as the Stedia process. Sorry, pause there. It is a small little bony process that usually fuses to the talus in most adults, but in some cases doesn't always fuse, and so you see that little growth plate that sits there? Great. So what happens is your patient will have a sustained plantar flexion moment, and the moment that I think of most often is when a patient in soccer is celebrating a goal and they slide on the grass and then fall backwards on their feet, right? There's that sustained plantar flexion moment. Certainly could have sustained plantar flexion moments with dancers as well. The sign and symptom for this os trigonum injury essentially is going to be pain with forced plantar flexion. So it's not like, passively you just plantar flex the foot and they have no pain. You actually have to apply an over pressure in the plantar flexion moment, right? That patient is also going to complain of pain in the Achilles tendon, and it may present to you like an Achilles tendinopathy. But what we know about Achilles tendinopathies is that they do not present with passive plantar flexion pain, right? So your differential right here for os trigonum is going to be that forced plantar flexion moment. They're also going to have pain on the posterior aspect of the talus. So not the anterior talar dome, but the posterior aspect of the talus. So again, in terms of etiology, this forced plantar flexion moment causes a fracturing off of this little Stedia process right here. And normally, like I said, in adults, most of them have it fused together, but sometimes it doesn't fuse. And so when it doesn't fuse, it makes it easy to fracture off. It becomes a loose body, right? So that an ankle joint can lock, just cause or wreak a lot of havoc in the foot and the ankle joint. If I'm a clinician and I suspect that a patient has an os trigonum injury, my first special test moment is literally going to be some type of forced plantar flexion moment. So in terms of treatment, right, you guys, let's talk about that. So in terms of treatment, Essentially, we need that patient to be non-weight bearing, right? And then we want to put them in some type of walking boot, right? And so if we look at anatomy here, this is the talus, yes. And then what we can see right here is this os trigonum and how it's kind of going to fuse to the talus, right? Most often it'll fuse and become attached. But again, if there's a forced plantar flexion moment, it certainly could break off and cause lots of pain in the foot. Next is the Achilles tendon and Achilles tendon pathology. Most often what we see with an Achilles tendon rupture is it's most often as a result of two different things. Sudden increase in load being placed on the tendon, and the tendon just can't handle that load. What we also see is that in terms of tendinitis or tendinosis, is most often it's a tight or rigid shoe that wears on the posterior aspect of the Achilles tendon, right? So we can have this chronic kind of wearing, which irritates the Achilles tendon, or we could have a sudden snap, acute load that causes an Achilles tendon rupture, right? There are many ways for this to happen. Most often it's going to happen in a dorsiflexion or plantar or a planting motion, right? In terms of predispositions, patient who has increased dorsiflexion range of motion because they're going to be allowed to place more stress or strain across that Achilles tendon. We know that ankle sprains have, for some reason, increased the risk of Achilles tendinopathies, in particular ruptures, and it's because of the swelling. The swelling will leak posteriorly, and then that swelling will then start to eat away at the Achilles tendon, making it more weak, right? And essentially leading to a rupture of the Achilles tendon. And then we know that hyperpronation of the foot stretches the Achilles tendon, so then it's going to increase the risk of some type of Achilles tendon pathology. So we know about tendinitis, tendinosis, and tenosynovitis. At least I think we do by now, right? There are 3 different kinds of grades of Achilles tendon pathologies. Most often, the first is the Achilles tenosynovitis, right? Which is an inflammation of the sheath surrounding the actual Achilles tendon, right? Most often, we would call that tenosynovitis or peritendinitis of the tendon. Then we have tendinitis, which is an actual inflammation of the tendon. And then tendinosis is like no bueno, right? It's where the inflammation infiltrates the actual tendon and starts to cause degeneration or degradation of the tendon itself, making it extremely weak and ripe and ready for some type of Achilles tendon rupture, right? So what are the signs and symptoms of a general Achilles tendon pathology, right? Want to catch it before it leads to an Achilles tendon rupture. That's the goal, I think, for most clinicians, is we treat the itis first before it becomes a rupture. And so signs and symptoms, most often going to be pain somewhere along the Achilles tendon itself. And then crepitus, right? Crepitus is like that chalkboard sound that you'll feel as that patient dorsiflexes and plantar flexes. We also see tightness. So in other words, they might lack dorsiflexion range of motion sometimes. And then what we can see if it's a tendinosis is what you see here on this slide, right? That Achilles tendon is just way thicker than the healthy Achilles tendon. That's probably a ruptured Achilles tendon. So that's probably a little drastic, but you'll see a tendon that's probably 2 times the size of the normal tendon itself. In terms of stretching and or treatment, essentially what we do in no particular order is to stretch the gastrocs if they are tight. Oral anti-inflammatory drugs if our patient can handle that. And then I would say last but not least is a cortisone injection. And I say be careful here because what we know about cortisone injections, in particular at the Achilles tendon junction, is there's a high rate for rupture. So you have to be really careful. You have to make sure that your patient is actually resting with a cortisone injection if you give it to them for Achilles tendinitis. I've been mentioning Achilles tendon rupture a lot, and so I think it only makes sense to talk about it, right? An Achilles tendinopathy, whether it's an itis or an osis, will lead to an Achilles tendon rupture. So if I say nothing else, I'm saying take care of the itis, treat it more conservatively before it leads to an Achilles tendon rupture. Achilles tendon rupture surgeries are not fun. They actually take longer to heal themselves than does an ACL rupture repair nowadays. So in terms of mechanism of injury, it's that increased tension or load on the Achilles tendon, most often as a result of an overload of the Achilles tendon junction. We see it often happen most following a cortisone injection or following a very long path of inflammatory response, whether that's an ankle sprain where the swelling just went into the tendon, or they actually had an inflammatory condition, right? So why does it happen? Two reasons. Either there's chronic degeneration, right? Or the gastrocs either don't fire and protect, or the TA doesn't fire or protect so that the tendon doesn't rupture, right? So it could be one of two reasons. We know about Achilles tendon ruptures is they're most common in males. And then in terms of signs and symptoms, the number one sign and symptom that is not listed here is that your patient will feel like they've been kicked in the back of the limb. And then they'll have the inability to push off, I'll say forcefully. Can they still push off? What do you guys think? The answer is yes, because what's still intact? The soleus is still intact and the plantaris is still intact. So they still have the ability to plantar flex, just not as forcefully as they would have as if the Achilles tendon, right, was intact, because it connects to the gastrocs, right? So they're just not going to be able to push off forcefully. So let's talk about Achilles tendon ruptures and testing. The special test for an Achilles tendon rupture is the Thompson's test. You can tell it's not a very good special test, but it's what we have. We're 40% sure, if it's negative, right, that they don't have one. So we still probably need to refer out just to get an MRI, right? Because this doesn't make me feel good. 40% sure, right? If the test is negative, that's not going to make my heart happy. It's not going to make my athlete's heart happy either. So let's take a look at the Thompson's test so you guys can see what that would look like when a patient is out cold. So when we squeeze the calf of the healthy foot, right, the one that has the mark, we see plantar flexion occur. We squeeze the gastroc of the injured foot, you can see that that plantar flexion is not happening, right? It's because we don't have the Achilles and the gastrocs connecting to one another, and as a result, a positive Thompson's test would be one in which you squeeze the gastrocs and no plantar flexion occurs, right? We'll refer out for an MRI and then they'll go in and they'll have surgery. Now in this bottom image here, I really love this one because we can see, look, do you see the Achilles tendon rupture? But then we still have the tendon of the plantaris intact. I don't know if you guys get excited about that, but I do, right? It's a really good image, a depiction of the relationship between the Achilles tendon and the plantaris tendon there. Okay, so in terms of treatment, they're going to have surgery to repair, right, the Achilles tendon. Keep in mind that when an Achilles tendon ruptures, most often what you're going to get is a little bit of a rolling or a ball that kind of exists in the skin. And so you'll see that in your palpation. And so it makes it really hard to retract all of it and connect it. And so the hard part with Achilles tendon ruptures is really the fact that the patient never truly regains full strength after the surgical intervention. So what am I saying, guys? Fix the Achilles tendonitis or tendinosis so that this doesn't happen to your patients. All right, the next pathology are peroneal pathologies. And there are two different ways to injure the peroneals. Number one is through overcontraction. So you have a dorsiflexion eversion moment. So a hypercontraction of the peroneus tertius, right? Because that's what the peroneus tertius does. But you could also have, believe it or not, a stretching of the peroneals, right? So if they plantar flex and maximally invert their foot, then you can stretch. What we typically will see is with peroneal injuries, if the range of motion is great enough, is that you can actually rupture the retinaculum. So you can either rupture this retinacula here or this retinacula here. And if you do that, remember what can happen is those peroneal tendons can then snap over. Remember, they can snap over the fibula and they'll change their angle of pull, right? So they'll be more like the tertius. They'll be dorsiflexors instead of plantar flexors. So if that makes sense, the retinacula is extremely important in maintaining that structural integrity, in particular of the fibulari or peroneal muscles, because it's what keeps them in the lateral compartment. Any compromise to them, any injury to them, and now they become most likely anterior compartment muscles, which is okay, but they no longer have the ability to kind of plantar flex the foot and may not have the ability to control the rate at which we invert the foot, okay? So this becomes extremely important to recognize. Now, let's talk about peroneal injuries in particular. You certainly could have a strain, but most common if we have a peroneal or a fibulari injury, it's going to be a peroneal subluxation. I'm going to show you what that looks like. in this video here. But essentially there are 3 major reasons that a patient will suffer from a chronic peroneal subluxation. The first one is the groove through which they sit. So I'll go back here. The groove right here is extremely shallow. So they're already ripe and ready to be moved to the anterior compartment. The other is we continually invert our foot and have inversion ankle sprains, and as a result the retinaculum gets stretched. And then last but not least would be laxity, just they're born with a congenital laxity of the retinaculum, right? So the sign and symptom of a subluxing peroneal is literally what the name implies. You're going to see those tendons subluxing over that fibula. So here we go. So take a look at that. We're going to resist eversion, and you'll see those tendons just popping. Now that normally should not happen if we're thinking about that, because they should have a retinacula right here that's keeping them intact. So that's what a subluxing peroneal looks like, and it is extremely painful. You guys are probably like, oh, Dr. Cosby, that's no big deal. But imagine like that tendon snapping over that bone. It's going to cause bony pain. So what can we do for these individuals besides surgery, which is our third option? We can tape it. We can tape the ankle joint, or we can use this. We can create like a felt pad, which sits right here, and we kind of recreate that tunnel for our patients. If the tape doesn't work, if the felt pad doesn't work, then we have to have surgery. And what they'll do in surgery is they'll basically kind of saw or drill a deeper groove for those peroneals to sit in, and then they'll probably recreate the retinaculum out of some other tissue within the foot and or the lower limb or the ankle. Okay. All right. Medial tibial stress syndrome is shin splints, as many of you guys might know them. But essentially, medial tibial stress syndrome is an inflammatory condition most often caused by repetitive use, overuse, and or training errors, right? Now, there are other causes for medial tibial stress syndrome, which could include patients not wearing the appropriate shoes for their particular foot type, right? Example, we talked about a few things in lab, but examples would be Vans are extremely flat, right? So if a patient has planus or a hyperpronator, Vans wouldn't be the shoes for them, right? It's going to overload that tibialis posterior, the posterior tibialis muscle, and it's going to create an inflammation on the medial side of the tibia. We could also have biomechanical abnormalities. And then last but not least would be muscle fatigue. So that tibialis posterior just isn't able to control the rate at which the foot falls into pronation, right? Because just think that tibialis posterior, its major role is to do what? Foot inversion concentrically, right? And plantar flexion. So if it's stretched or if it's fatigued, it's not going to slow down the rate at which we move into pronation, right? Eccentrically, it's not going to function very well. So when we're thinking about medial tibial stress syndrome, let's look at this here. What we know about medial tibial stress syndrome is it can be caused by many different things, but most often there are typically 2 causative factors. It could be the soleus, certainly, but most often what we see happening is that the tibialis posterior muscle, which if we think about Tom, Dick, and Harry, is the closest in contact with the medial border of the tibia. That muscle either gets stretched and overused, and as a result, what we typically will see is as that muscle's getting stretched, right? As that muscle's getting stretched, it will tug on the periosteum or the tissue lining the bone and cause irritation up and down the tibia. So if we go back to this slide here, you'll kind of see like ultimately what happens is it just starts to pull away from that tibia. And then what we see happening at first is the muscle gets inflamed, essentially. That would be like a grade 1, the muscle gets inflamed. And then what we see is there's this sheath lining the bone. That sheath gets inflamed. That's called periostitis. And then the third would be what? A stress fracture, right? So the ideal would be that when we're thinking about the etiology of medial tibial stress syndrome, reducing any of these, improving training errors, correcting shoe wear, strengthening, right, the deep posterior compartment muscle so they can control the rate at which the foot is falling into pronation. All of these things will reduce your patient's risk of developing medial tibial stress syndrome. But etiology-wise, it is irritation and or inflammation of the tibialis posterior most often. Certainly could be the soleus as well. Now, remember, there are grades to this. Our grade 1 would be irritation of the actual muscle. Grade 2 would be irritation of the periosteum, right? Which is this small sheath surrounding the bone. So it's like swelling in between the sheath and the bone, right? But we haven't quite gotten to the bone yet, right? If we don't stop there, then essentially what happens is the patient develops a stress fracture, right? We know that a stress fracture is an overuse injury. We know that medial tibial stress happens as a result of overuse, training errors, shoe use, muscle fatigue, right? Just to name a few. So what I'm saying to you is if a patient comes into you with a stress fracture, it's because they had medial tibial stress syndrome first, and maybe they were in season, so you thought, oh, let him get through it, right? So if we correct medial tibial stress syndrome, then essentially we can improve the rate of stress fractures or the number of stress fractures that we see in our clinic. And let me tell you, tibial stress fractures are relatively hard and difficult to treat because the tibia is such a weight-bearing bone, right? So with stress fractures, what we know about them is they are as a result of microtrauma after microtrauma after microtrauma after microtrauma. I could keep repeating it, but you don't want to hear it again. The moral of the story is what, you guys? It's an overuse injury that you could have seen coming prior to them walking into your clinic, right? What we know about stress fractures is that in general, pain increases with activity and decreases with rest, but never goes away. So they're constantly in pain. It's just a matter of how much pain they're actually in. In terms of special testing, the number one sign and symptom for a stress fracture is what you all said, night pain. We can also do the HOP test, which we'll talk about in lab, the bump and compression test, and then last but not least, the torque test, which we'll show you in lab, would be bending that tibial bone and causing splintering of the fractured pieces. Okay, so let's talk differentials really quick, because you guys are all like, oh my goodness, Dr. Cosby, you've talked about stress fractures, you've talked about shin splints, and one of the very last pathologies that I'm actually going to talk about is compartment syndrome. So let's go here first. If we're looking at type of pain, right? Let's look at shin splints and let's look at stress fractures, because I really like this chart. If it's a stress fracture, it's localized. Do you see that? If it's shin splints, it's diffuse, so it's all over the place. Does that make sense? Okay, let's look at pain with rest. It decreases or disappears. Do you see it? Whereas with the stress fracture, it's there all the time, especially at night, which makes sense, right? So we could look at all of these things and we could say, what are the differentials? How do I know when my patient has a stress fracture? I'm telling you guys, it's all about the night pain. So let's talk about compartment syndrome, and then we'll go back to that chart if it makes sense to do so. So there's compartment syndrome. The name implies that this is going to be a syndrome to one of the three compartments that we have, right? So the lateral compartment, the anterior compartment, or one of the two posterior compartment groups, right? So what we know about compartment syndrome is that it results from increased pressure within the compartment. So I'm just going to say off the bat that anterior compartment syndrome is by far the type of compartment syndrome that you're going to see in the clinical setting. So we'll only talk about that in this class, but you certainly could kind of take all of these and apply them to any compartment within the human body, right? So anterior compartment syndrome results from increased pressure within the actual anterior compartment, right? The concern with a compartment syndrome is that that increase in pressure is most often as a result of some type of swelling, some type of fluid, or muscular hypertrophy that obstructs the neurovascular network. Let me say that again. If we have a lot of swelling in the anterior compartment, and if that swelling compresses, right, on either the peroneal nerve most often, then it's going to cut off that nerve's ability to supply the rest of the body, right? And so we could essentially lose that limb. Make sense? It's life-threatening, or at least limb-threatening, right? Most often when we think about etiology, what we know is that it's usually a direct blow to the tibia that does it. So most often we see anterior compartment syndromes in soccer and in field hockey, okay? In terms of signs and symptoms, they are the 5 Ps. You need to know these for your exam. So it's pain, it's pallor or redness, pulselessness means we assess the pulse distally, most often it's going to be the dorsal pedal pulse or the posterior tibial pulse. They're going to have numbness and tingling going into the toes, and they may have paralysis, right? Of what? The anterior compartment. So in other words, that patient probably will have foot drop, right? Because the anterior compartment does which two motions? Toe extension and dorsiflexion. So if our nerve is compromised, we won't be able to dorsiflex the foot, right? So they'll have foot drop. Hopefully you guys are picking that up. So compartment syndrome types, there are two different types that we most often see. There's traumatic and there's chronic. What we see with traumatic is a direct blow actually happened to the compartment, swelling ensues, and as a result, guess what? Starts to compress on the compartment. That's intuitive. It's traumatic, direct blow, there's swelling, there's a lot of swelling, compresses the nerve, medical emergency, right? What's not intuitive and what I've seen most often is the chronic form of compartment syndrome, which only happens when the patient exercises. So patient's fine, patient goes to exercise, because there's increased capillary permeability, because there's increased blood flow naturally with exercise. What happens is the muscle hypertrophies, there's lots of blood flow, and there's no give of the fascia surrounding that particular muscle group, right? And so as a result, that compartment can't handle the hypertrophy, can't handle the influx of blood flow, and so it starts to compress on the nerve, and it gives the 5 signs and symptoms. But guess what? The good news with the chronic compartment syndrome is it goes away once they stop exercising. The hard part for us as clinicians is how do we convince a coach that a patient has this? Because the only time it bothers them is when they're practicing. So you can see where I'm going with this, right? If you have a patient who the coach questions whether or not they actually want to practice, this would be the worst pathology to have. But it happens in the clinical setting. You just have to make sure that you don't ignore it, right? Because they'll come in and they're like, oh, I can't practice. They have numbness and tingling. Well, does it hurt now? Is it numb now? Is it red now? No, it only does it when I practice. And so sometimes you won't even be able to see it. So you'll have to reproduce their signs and symptoms. So this is the first time that we're talking about the concept of a lower quarter screen, right? We actually have to do a lower quarter screen here to see if our dermatomes, our myotomes, and our reflexes are intact, right? Okay, so what do we do if we miss an anterior compartment syndrome? Essentially what we're going to have to do is what you see here, which is a fasciectomy. They're gonna have to open up the compartment and let all of the swelling out, right? It's the only way to save a limb. So we hope that we catch it sooner. One of the ways that we catch it is through this process right here, which is an intercompartmental test. Now you can see that needle and you can see that this isn't a fun test, but I'd rather have my patient go through this type of testing than to have them go through this type of surgery. So what you're getting ready to see is a physician who's going to insert this pressure gauge into the anterior compartment, and they're going to look at pressure and then they're going to compare it to the other side. And essentially what they say is any pressure that is greater than 30 millimeters of mercury side by side, they then go in and they have to do a fasciectomy, right? But the fasciectomy is a lot smaller than what we see here, right? So it's extremely painful. Make sure you know that this is the pathology because none of us wants this to actually happen to us if possible. So what I've been describing to you guys is exertional compartment syndrome, which is brought on by exercise, right? So that patient is having a compartment syndrome that's as a result of exercise that typically doesn't go away until about 10 or 15 minutes of activity, of ceasing activity. So the signs and symptoms of exertional compartment syndrome: muscle tightness, cramping, swelling, weakness, inability to exercise. Does this all sound like dehydration as well? So we're going to have to be careful in how we diagnose this, right? Is it dehydration? Is it actually exertional compartment syndrome? What do you think the key diagnostic historical question would be? If you said, is there numbness and tingling associated with this? Absolutely, right? With exertional compartment syndrome, you're going to have some numbness and tingling. With a dehydration patient or a dehydrated patient, they shouldn't have any numbness and tingling, right? So how do we know? We will have to do that pressure test that we just saw on the other slide, right? We're going to do that pressure test. And so what we say is, okay, we're going to test them before practice and see if the difference is 15 millimeters of mercury at rest. Then we're going to have them exercise. We're going to see if that pressure goes up. Then we're going to have them rest, and we're going to see, okay, what does it look like 5 minutes afterwards? If that pressure stays up, then we are concerned about exertional compartment syndrome. Here's the problem with exertional compartment syndrome. I've had athletes have surgery and it still does nothing for them. Most often it's as a dysfunction of the tibialis anterior muscle, right? So the goal then would be like myofascial release, right? Some type of instrumented muscle tissue techniques. You're trying to really work with that fascia because surgery typically doesn't work for these particular patients. And finally, I saved the best for last because it's the most life-threatening. I've had a family member actually die from a deep vein thrombosis after having knee surgery. So this is near and dear to my heart. I don't know why I saved it for last because this is such a long lecture that you probably all aren't listening now. But this is a deep vein thrombosis. A deep vein thrombosis is essentially a blood clot being formed that gets dislodged and essentially blocks blood flow to the heart and essentially leads to cardiac arrest in your patient. So it is extremely life-threatening. We see this most often in post-knee surgery. And so it becomes important to assess and screen for, to screen for this pathology. And so the best way to do that is with Homan's test, and we'll do Homan's test in the lab, but essentially you want to have that patient lying in a supine position, you want to flex their hip with the knee extended, and you want to dorsiflex that foot, and you want to see if they have extreme pain. If so, that's an immediate referral, you guys. If you look at the sensitivity and specificity of this test, you'll see that ultimately Homan sign and the amount of calf swelling will be high predictors of a patient who has deep vein thrombosis. The hard part, you guys, is post-surgery, you're thinking, oh, nothing can go wrong. Seriously, cousin, knee surgery, next day, wife found him in the bathroom. So it is possible, and all because there was a deep vein thrombosis that no one knew was going to happen. So with your knee surgical patients, for the first 3 days post-surgery, you want to check their calf to see if they're complaining of any calf tightness. And then if they are, you want to do a Homan sign and you want to assess the calf for swelling. And in the first 3 days, if they have calf tightness, if they have calf pain, you're okay to just refer out because we don't want our patients to die from a deep vein thrombosis. Anyways, thank you for listening. I hope this has been helpful. I look forward to seeing you in lab where I can show you all of these techniques. I hope you guys are doing well. Thank you for listening.